For the study of multi-organ failure, I chose the topic of skin failure in an article titled Skin Failure in Acute Care, Unavoidable? Skin failure is an ischemic event that causes tissue injury and cell death due to hypoperfusion, resulting from shunting of peripheral blood to the core during a critical illness. Its pathogenesis includes hypoxia, dysfunctional delivery of nutrients, and stagnation of toxic metabolites in a zone of injury. The pathophysiology of skin failure is described as a state where skin is wholly intolerant of stress and minimal local mechanical impact. Skin failure is a separate occurrence from pressure injury. Pressure and shear are not required for it to occur. However, they may occur concomitantly. Nurses are generally well versed in skin integrity issues related to pressure ulcers, including assessment, diagnosis, and intervention. Typically, there's annual competency reviews. However, the distinct evidence and lack of clear-cut diagnostic criteria related to assessment and management of skin failure make it necessary to teach and stay current in the research to ensure the development of skin failure is appropriately anticipated and identified early on. These wounds develop despite vigilant, competent nursing care and occur due to patient condition and resulting hypoperfusion rather than pressure. Unfortunately, healing is often slow and may not happen without drastic intervention following the injury, such as surgery or flap repairs. Skin failure on its own is not a nurse-sensitive indicator of care, and it's not sufficiently mitigated with offloading devices and other types of typical pressure ulcer management strategies. Acute skin failure is associated with myocardial infarction, septic shock. Chronic skin failure is associated with chronic disease, including cancer and multiple sclerosis. And end-of-life skin failure with end-of-life problems, including renal failure and pulmonary fibrosis. Bartsak delineates identification and management of skin failure from usual medical surgical practices surrounding assessment, diagnosis, and interventions. Bartsak proposes separate models or paradigms of measuring and understanding skin injury for skin failure as compared to pressure ulcers. This is necessary because the etiology and the prognosis of skin failure is far different. And skin failure does not typically respond to normal offloading procedures. I think we've all seen skin failure, such as in the first picture. I've even seen skin failure like the one on the front actually become towards the end of life blackened even further and just literally cave in the leg. We've seen necrotic fingers and toes. We've seen this yellowish necrotic rough breakdown on patients in complete septic shock when we've looked after them in ICU. Bartsak really brought to home for me the need to assess and identify these wounds differently and to understand that a four eyes approach to assessing wounds may help in this endeavor of not misidentifying an acute any type of skin failure wound with pressure ulcers. We can't expect the same outcomes. And just as a patient who's had pulmonary failure may go home with some respiratory residual effects, patients with acute skin failure may likely go home with residual effects. And these effects don't have to be associated with nursing care because they are a system failure. I do appreciate your time, and I hope you had something good come out of this lesson. Thanks. Bye.